For the purpose of this recording, just so you know, the reason you get me for documentation is I've been a nurse since Christ was an altar boy, but one of my side hustles was that I did medical malpractice chart reviews for attorneys, have been qualified as an expert witness in forecourt systems. I can't stand the actual process of documentation because I'm a terrible typist, but I love chart review. I love documentation. I love making sure the pearls that should be in a chart are in a chart, that there's no extraneous charting. So I'll go through the process of image trends with you and then just throw a couple little pearls out there. I'll try not to overbore you, but if anything is too much, just tell me to shut up. And otherwise we'll keep going on. So what we've done is we've logged into Image Trends. Image Trends Elite is a web-based documentation program. There is a local documentation program on all of the Toughbooks in the chart. If you do a local chart, that stays on that computer only until you link it to the web. So the problem with the Elite system with being in the ambulance, if you get into a spot where there's poor cell service or poor internet, you may lose your chart and not have the ability to save it. So where if you use the local chart, you can do all of your chart on that one computer. And then when you get back to children's, you can upload it to the Elite system. So it's a little bit safer so that you can maintain it. So we're going to just do this on the Elite system. It's basically the same thing, but it's an easier way to get everything going. So when you first log into Elite, you're going to have your announcement form. This is if there's anything that leadership wants you to be aware of before you start your day. To start a chart, you're going to go to Incidents. View Existing is if you've already started the chart, somebody else has already started the chart, or you need to sign a chart. If you're going to start from the beginning, you're going to create a new. And then it just does an update every time that it opens for the first time. Once you've opened it for the first time in the day, you won't have to worry about doing the updates. Oh, how do I get rid of this? When you're actually doing a call, you would hit the CAD button. We are not going to actually connect to a CAD chart because this is just going to be a dummy chart. But when you're in the unit or back here in the office charting afterwards, you'll see what unit were you on? Where did you go to? If this was your call, we would hit this, and then it would go ahead and populate into this record the run number, the patient's name, the patient's date of birth, things of that nature. If you don't have that information, you don't have to do a CAD upload before you start your chart. Any run of numbers here will be able to let you save your chart. So if you just do this, and then you can change it when you get back. So we're going to just go ahead and do a dummy chart as we're moving along here. So we're going to say that this is a pediatric patient. And then what we're going to do is, just so Dan knows to delete this chart, we're going to make this child's name delete. Otherwise, it'll go into the system. So this is the first page that comes up when you log in, and you want to make sure all of this is correct. A CAD upload will include this page. But if it's not in there, if you haven't done the CAD upload, go ahead and put in all that you can. So BLS we don't do. As a nurse, you'll never be on a BLS call. ALS calls we do, and specialty care calls we do. If you go along on a call, just because we have an extra nurse, it doesn't automatically make it an SCT call. If you're just going along to be helpful and it's still an ALS call, there's nothing that falls outside of the scope of practice of a paramedic, it's still an ALS call, because if we start billing specialty care calls for things that aren't specialty call, that's Medicare fraud.
Okay.
So this is, all these things have a lot to do with billing and regulatory things.
So are specialty care calls just Charlie and above?
Mm-hmm.
Okay.
Yeah. Anything that falls outside of the scope of practice of a paramedic.
Okay.
So your dispatch triage is how the call was actually paged out. So P3 Charlie ground because you're going. If you get there and you feel like the patient should have been something else, there's a spot later where we're going to be able to differentiate that. But this is how the call was actually triaged. So we're going to be going page by page through this chart so we can get everything together. One thing that I like to share, the chart has 3 actual purposes. The primary reason, which we all believe in the most, but is the least reason for a chart, is communication between care providers. It's to be anybody who picks up this chart, looks at this chart through the hospital system should be able to know exactly what went on with that patient from start to finish. The other reasons for it is billing and covering your ass, unfortunately. So we want to try and complete a chart as quickly as possible, because you'll notice that when you go and check up on a patient later and you look at their H&P, half the time it says that we did things that we didn't do, and it says that we didn't do things that we did do. So when you give that bedside report, a lot of it does not actually get transmitted to the care providers down the line. I honestly don't know who actually reads our chart, but at least you've got all that information in there. So we've got our first page, and all of these tabs here to the left correlate to a page that opens. We can go next here, or we can go down here and do our next. You'll get a exclamation point if there's something that still needs to be done on that page. But once the page is completed, the exclamation point resolves. You've got a validation score here. You want to get to 100. You cannot lock a chart until everything that needs to be in the chart is in the chart. And it'll let you know by these little exclamation points on each page what you actually need to put in the chart. So crew members, you have to have a nurse, well, excuse me, you have to have an EMT and you have to have a medic. And then after that, anybody else is just extra. So we have our nurse, we have our paramedic, and then we need an EMT. Let me scroll, we'll go butler driver. If we have a fill-in and it's somebody that's not in the system, we can just make them butler driver. And that way there's something in the system. This referral information will populate if you do a CAD import. You can CAD import at the end of the call as well, and that's how your times are updated. So if you don't have this information, you don't have to put this in as you're going out, as you're doing the chart yourself, because this will populate later. So responding information is something that we will fill out. Number of patients, single. We always do single. There have been rare cases where we've done double transports. But to do a double transport, we need administrative approval. It's like siblings can be transported in the same unit if there's a significant delay and not significant illness or injury. So all those would require AOC approval to do more than one. So we're usually singles. So we have a couple different ways that we can mark the patient disposition, and this basically shows what pages are available to us in the chart. Treated, transported by this unit is pretty much what we always do. Patient refused care, we have them that refuse care. But that's if you get canceled before you arrive, then you just dump the chart, there's nothing. Patient refused care is if after you've made contact, the family has said no. Treated and transferred care to another transport unit if we've had situations where we've backed up other transport teams because they couldn't get the kid on their ventilator, or they didn't have the didn't feel comfortable doing the care that was required for the kid, or they didn't have high flow. So that would be something that another team would do. If you get on the scene and you care for the kid and the kid is just too sick for you to take by ground and you transition to air, you can end your chart right here and hit that the care was transferred to the flight crew. Organs, that type of thing is a different chart, but that would be not us run. That would be just something where a safety officer goes. Patient assessed and treated, not transported. This is if you do anything and you need to document it. So if you do the refused care, you're not going to have any place to document anything, basically. All of the pages are going to gray out. So we've had situations where we've gone to outside hospitals and the parents don't want to go. Well, hey, let's just do a repeat set of labs. The patient was coming over for a lab issue and we'll see what the labs are. So we've done an epoch. So we need to have a way of billing for that. And we need to have a way to document what those lab results were. So this chart will give us basically a shell so that we can put that information in. Dead at scene without interventions. I don't understand this one because either we're doing something or we're not doing anything at all. But without interventions. Dead at scene with interventions, we do a lot. We were discussing yesterday that will go to CPRs in progress and help them out. So you can choose to announce when you get to the bedside that you're not assuming care, and your chart is going to basically reflect that you assisted the outside hospital with the resuscitation process, the time of death, who pronounced, and it's usually going to be the outside hospital because you never assumed care. So who pronounced and that kind of thing. Operational support is basically when the medics go out as safety officers and they meet a fixed wing crew coming in, or just do some type of a transportation, but the care is maintained by the crew that already has the kid. We're just going as a safety officer for our trucks and our equipment. The cancel charts we actually don't do anything with. But for the process of today, we're going to go treated and transported by this unit because that's our usual. Response mode to the scene. Totally self-explanatory. No lights or sirens is our primary. You can call the outside hospital and get report on the way out. And our policy is you call the outside hospital on the way out and get report. I always like to do it when I'm about 10 to 20 minutes out. Gives me an opportunity to start my chart because I'm the world's worst typist. You can fill in their history of physical, or excuse me, their reason they came to the hospital. You can fill out the information that they give you, how many meds they got, what meds they got, where their IV is, things of that nature. But you can also ascertain how sick the kid actually is at that point in time. And if you feel that you need to go lights and sirens, you can upgrade at that point in time. So we usually always start out no lights and sirens, and then you have the ability to upgrade if you need to. If you start out lights and sirens, or if you start lights and sirens and you talk to them and everything gets downgraded. To do lights and sirens here, we have to do a matrix, a safety matrix. Is it worth the risk to go lights and sirens? You only gain a very few minutes with going lights and sirens, excuse me, and your risk is increased exponentially. People slam on the brakes, people don't go the way they're supposed to. So it is a safety risk to go lights and sirens.
Okay.
Or if we go by rotor, but our primary is no lights and sirens. Transferred to is usually us. We do transfer to other places. We do the military shunt runs where we go to other military facilities. The NICU does a lot of transporting from one hospital to another when the NICU is full. We do mutual aid to different things. We do take kids out of here to other facilities. We take kids to CHIP and CHOP for specialty procedures. We go to Hopkins, we go to Georgetown, things of that nature. If you're doing a rad run, their return destination is here. So Sibley is only a pit stop. So their destination back is here. There are kids with AVMs. There is one pediatric interventional neuroradiologist in the area. And she does a month here and she does a month at Hopkins. So depending on where she is where the kids go. So it's pretty common that we'll take kids that need coiling to Hopkins. We'll also take adults to the hospital center. And then that's basically it. But the primary destination is usually going to be us. So CAD dispatch does a lot of this one. What time the call received is what time the call actually comes into ECIC, your dispatch time. So ECIC will input sometimes, but they're not always the correct ones. So you have the time that you arrived on scene, and then you have the time that you arrived on patient, and they can be very, very different. Some places the ambulance bay is right outside of where you're going. Some places the ambulance bay is 4 hallways and 3 floors away. So I always take note of the time that you actually arrive at the scene, because that's when your clock starts, and that can be very, very different. Same thing, the time that you left the scene is the time that you actually are leaving the patient's bedside. So that includes your walk through the hallway out to the ambulance. It's not the time the ambulance physically leaves the building. It's the time you're actually transitioning with the patient out of the building. The time you get here and transfer of care can be two entirely different times. And we ask you to try and mark that. We've had some problems with some floors that when we go to drop the patient off, we're at the bedside for 30 minutes before we can give a report to somebody, or we're at the bedside for 40 minutes before we can give the report to somebody. We mark with ECIC, we call them up and let them know extended bedside time, and they put a notation in the dispatch record. But we also use it for tracking. At one point in time, we were having an issue with one particular floor where we had extended transfer times. And Children's is very data minded. So Liz was able to go with the, hey, you know, this amount of kids, this is the amount of time we spend at the bedside waiting to transition care. So it kind of gives a little meat if we're going to have any type of a complaint. And then unit back in service really doesn't matter, but it just has to be past the time that you transferred care. We have 20 minutes or 30 minutes through ECIC before you're dispatched. You can be dispatched again. So a lot of times you'll hear somebody say something, well, can Medic 2 take this one, or can Medic 1 take this one? And you'll hear, especially Mike and ECIC, they have 18 more minutes until they're dispatchable, or they have 4 minutes until we can dispatch them, because there's actually a policy as to when we can be able to be dispatched. If you've had a really bad call and you really used everything in your truck and you need to do a lot of restocking, a lot of cleaning, things of that nature, you just need to call ECIC and let them know that you have extended decon, you have extended restocking, so they know that that clock does not count for that one, because otherwise they will go right ahead and dispatch you.
Are there any infectious processes that require a longer decon?
If there's a breach, if you have a COVID kid with a breach, so if they're masked the entire time, you're fine. But if they take their mask off at any point in time, then you have to go through breach protocol, where the ambulance has to sit with the doors open, somebody has to babysit it, it has to be wiped down, things of that nature. Anytime you feel that you need to decon your truck, you just tell ECIC you need to decon your truck. You're more than welcome to. All right. Next page, we're going to say that this is a female, and we're going to say June 20th, we'll say 2005. So if you put a date of birth in and then just tab down, it'll automatically fill in their age. Let's go with 2015 instead. All right, we'll stay with this. Whether that weight is actual or an estimate, if you put in pounds, it will fill in kilos. If you put in kilos, it will fill in pounds on this page only. And then medical record number and account number will be on your pre-arrival form. Or if you, on the off chance that stickers have actually printed, you'll have stickers and it'll have that information as well. When you do your CAD import, this will come in also. All righty, HPI narrative. To me, this is the whole meat of the matter. I want to know, who are you? So we'll say that this is a 17-year-old female. History of complaint of for how long? Whoops, no, sorry. So who are you? 17-year-old female, history of whatever. Why did you think you were sick? So abdominal pain for 6 months, nausea and vomiting. What did you do at home? So it would be Tylenol and Motrin without success. Seen by PMD, started on an antibiotic, still felt bad. So then the next question is, why does the other hospital think you're sick? Ooh. So presented to the outside hospital, CBC, CMP done, resulted with ABC, concern for XYZ, and then what's happening here at Children's. So patient transferring for surgical evaluation, not available at outside hospital. Patient transferring for PICU level care and management, not available at outside hospital. Patient transferring for endocrine evaluation. So if you're bringing them in for a subspecialty, we always put they're coming in for a subspecialty evaluation, not a consult, because according to the insurance company, consults can be done over the phone.
Okay.
It's a little bit of making things work. So that's the big thing. Who are you? What initially? 17-year-old congenital cardiac. Why did you think you were sick? 4-day history of. Why does the other hospital think you were sick? They saw this. Why are you coming to us? Coming for boom. So this should be very, very meaty. Why does the other hospital think you were sick? Was it included with that is treatment? They gave a normal saline bolus. They gave morphine. They gave Flagyl, they gave ceftriaxone. We don't say what the dosages were that the outside hospital gave, because it's in their documentation and we don't want to have anything muddy. If we realize that the dosage was inappropriate, you can document it here, reported to have given. And so I don't know why outside hospitals try to dummy down their meds, but they try to just give a lump sum dose, but it's not based on anything. So we'll go to a lot of hospitals and the child will have received 10 per kilo of ceftriaxone. It's like this was a useless dose.
Right.
So you can put in your HPI, reported to have received, so that you've addressed the fact that that's what they've done. But we don't actually give the dose or dose otherwise if it appears to be a normal one. So again, this is what we discussed before, what time you actually hit the bedside. So if you hit the little clock, it automatically gives you the now time. This means that you can hit a not applicable. And that's what most of these things are. Is this a medical or is it a trauma patient? A lot of times we don't know when the symptoms actually occurred, and that would be the time that you would do the not applicable or not recorded. This is just basically body systems. We'll go genital urinary, and you just pick whichever is the most appropriate. So you have a drop-down list here, or you actually have a listing with this menu. So you've got a couple different ways to work it, whichever way works best for you. Anything surgical, of course, we'll put down the last PO. If it's not, this is not a mandated field and you don't have to do it. And of course, cardiac arrest, whether you did or not, or whether they had it or not. Barriers to patient care can be if they're hearing impaired, if they're developmentally delayed. We usually don't put anything down because most of our kids is just age related and it's just part of who they are and an expectation. It's nothing out of the ordinary. Medical surgical history has these menus that are propagated, but you can always do illness other, because 9 times out of 10, our children's histories are not something that's in a normal pick list. So Image Trends starts out as a blanket program, and then we put different fields in it, but it's only customizable to so much. And we can't put every bizarro history in that our kids have. So it's easiest just to put in the illness other and then list all of their issues. Whether your medical history was by the family or another healthcare provider, or if the patient was actually able to share with you their history, like our teenagers. Immunizations up to date if you have the ability to get that information. Medication allergies, the usual. So home medications, we only do names. If you get into names and dosages and times in day and stuff like that, that's going to take you your entire transport time. But JCAHO requires medication reconciliation anytime there's a transfer of patient care provider. So if you at least acknowledge the names, you can reasonably state that you evaluated if there would be any medication interactions, or it also gives you the ability to question as to further medical history that the patient's parents has forgotten to share. So, you know, the usual, somebody has no medical history and then the next provider comes and they actually have a medical history. The next provider comes and there's actually more medical history. So a lot of that can be determined by their home meds. But so all we actually need are names. Environmental allergies, if they are relevant. eggs, that kind of thing. So protocols, we have our standard protocol. Everybody gets standard. Standard is you go on the monitor, you have vitals.
Mhm.
Our protocol here is if they are stable, vitals Q 15 minutes. If they are a critical care patient, it's vitals Q5. So that's why when you go to the bedside, I am a firm believer of you take the monitor off the stretcher, you carry it into the room, you put the kid on the monitor, and you put the monitor on their bed while you're assessing, while you're doing everything else. I always get my first set of vitals off of the monitor at the bedside if they're on one.
Mhm.
And then my first recorded vital sign states that it's on the outside hospital overhead monitor. Then we bring ours in and we see if there's a correlation between the two. And then if you get busy at the bedside, and there are times that we've got 1 and 2 hour bedside times treating the kid. If you haven't put the kid on our monitor and you've assumed care, you have no way to document with all of those vital signs were the whole entire time you were there, because you are not copying off the overhead monitor every 5 minutes.
Right.
And the expectation is still Q5 minute vitals.
Okay.
So the easiest thing to do is just bring ours in and do it. We have a number of protocols that we've put into place. Some of them are totally signed off. Some of them are not, but they're all in our protocol booklet. Again, legally, protocols in transport situation have to be enacted individually for each individual patient. So our protocols are set up that if it's a life-saving venture, you can go ahead and initiate that and then call and get a post authorization from the medical control physician, but you have to be able to justify why you enacted that protocol before you got the specific order from the physician. You can always stop and talk to the medical control physician on your way out and say, hey, I'd like to implement our non-invasive airway protocol. I'd like to implement the fracture protocol. I'd like to implement the abdominal pain protocol. And if you get prior authorization, you're free to use it.
Okay.
Otherwise, you can only enact the life-saving measures and then call and get permission for the rest of them. But these are all things that we have in our protocol book. And basically the protocols here at Children's have been vetted through multiple organizations, through the pharmacy, through the PICU team, through the ER team, through the CI team if it's a cardiac. We only have a few protocols that are actually signed off on because the process is so extensive here. Everybody has to be a part of it. So if you do use one, make sure you actually have an order for it, except for standard clinical care. That's an expectation. Primary symptoms, whatever is applicable. Secondary complaint, we don't often use. And then your impression. Again, not all of these apply. So you're looking for whatever is the most reasonable as to what you're feeling. All right. You're controlling MD. So the physician that does your med control, that department charges a consult fee. So it's important that if it's an ER doc, it's an ER doc that's listed. If it's a PICU doc, it's a PICU doc that's listed, because then that either the ER or the PICU gets that consult fee. Also, the chart is routed to whatever the controlling physician is for them to sign it. So every chart that you have has to be co-signed by whoever the medical control physician was. So this will automatically push it to their inbox, and then they'll sign it, and then it'll push forward as a signed chart. If you ever have problems with a physician, if you have enacted a protocol and then you call the medical control physician and say, hey, I did this, and they have a problem with it, and they say, I'm not going to sign that off because I don't agree with what you did, we have Mike Quinn as a backup. You are going to have to justify why you did it, but you'll fill out a special report when you get back and let him know, hey, I did this, I enacted this protocol, this is why such and such physician did not feel comfortable signing my chart.
Okay.
So then he'll go over your chart. If you have not done anything yet and you're having pushback with the doctor on med control and the two of you just don't agree and you feel extremely strongly about it, you can go back through ECIC and they will put you through to Mike Quinn directly. And as our medical director, that's something he's agreed to do.
Okay.
So you always have backup. You don't have to feel like I'm at this point and it's an impasse and I can't do anything else.
Okay.
So it's nice that that frustration can not be
So for
there.
instance, yesterday, like the seizure kids that were being directed, directly to neurology, not the ones routed through the ED. If you're on the call, are you calling the MCO or are you calling neurology? Correct?
Oh, excuse me. So the MCOs have agreed to be responsible for us.
Okay.
Nobody else has.
Okay.
So the way transport works, paramedics are independent practitioners and they go by their protocols, they go by their state licensure. So they can do things based on protocol. As nurses, we cannot. We are order-based. And the neurology doctor can ask you to do something, but you're not legally allowed to do it under their license because you're working under Dr. Quinn's license. You're working whatever doctor has given you the orders, you're working under their license. So that's who you would get the orders from. Regular hospitalist admissions, the hospitalist has accepted them to the hospital, but the ER med control is in charge and garnering your transport time. So that's who you're getting the orders from. Again, it's all who has taken legal responsibility for you.
So in terms of acute care, the only time this changes is if they're going to the PICU or the SICU, then you can speak to the attending of the receiving ICUs, but otherwise it's the MCO.
Attendings or fellows.
Okay, depending on the unit preference.
Right.
Okay.
Exactly. Well, no, but that's all you can do, attendings or fellows. We have had some situations where the PICU tries to slide in their nurse practitioner because when the docs are in rounds or in conference or something like that, they give the phone to the nurse practitioner. Things are better now, but it used to be a lot of contention. Oh, I'm not good enough to give orders. It's like, no, it's not that you're not good enough to give orders. It's you legally, we're not allowed to take them from you.
Okay.
So we're only allowed to chat with an attending or a fellow. So we'll just put a name in. So we've got like 1,800 pages to pick a doc because every CI doc is in there, every PICU doc is in there, every ER doc is in there. So it's easier that it's broken down at least into alphabetical sections. Vital signs, again, Q 5 minutes for sickies, Q 15 minutes for stable kids. The exception to the rule is if you've got a really long transport and a really stable kid, you can get a specific order from the physician to only do vitals hourly.
Okay.
Our psychiatric patients, you can get an order from the physician to only do hello and goodbye vitals. Anything that's going to go outside of what our protocols are, you just need an order for it, and then you can do whatever you want to as long as you have a physician order for it.
So you have to record if it's like a sick kid, you're going to go in and manually enter vitals for every 5 minutes.
So we have the
taking care of.
ability to do an upload from the monitor system. And unfortunately, I don't know how to do that.
I've heard mixed things, that it's unreliable, that sometimes it screws up the whole thing. If it doesn't cross over exactly right, it could delete other pages. So what I'm getting from most people is just go ahead and print out the vitals from the monitor and manually put them in, because that's at least safer and doesn't mess up other tabs.
So you get everything if you do an upload.
Okay.
Every time the heart rate goes up because of road motion, or it doesn't get a blood pressure and it takes it, or you get a whack biscuit blood pressure. So it does record everything.
So now you've got this erroneous vitals that now you have to explain that look like the kid because the monitor's beeping saying he's in VFib. But
exactly.
Okay.
Or you can manually remove them, but then you have to go through and manually remove them. And it's a lot of extraneous information. Personally, I prefer to enter it myself.
Okay.
Especially on the ambulance, when I'm documenting in real time, a lot of people will go through the history and physical, they'll go through the assessment, they'll go through the meds and document that, and then document vitals when we get home.
Mhm.
My personal preference is to go to the vitals page and do the vitals documentation in real time, and then fill out those other pages in between the vital taking.
Mhm.
Because if I'm just doing regular charting, I'm not honestly paying attention to the vitals every time they change.
Sure.
So if you're documenting the vitals in real time, it kind of prompts you to actually look and see what's going on every 5 or every 15 minutes. So of course, this will give us our time for now. Heart rate, whatever it is, all of these things are pretty much self-explanatory. But not all of them are required. All of the boxes here are required. So anything that is applicable, you'll fill in. If it's not applicable, you just leave it blank. End title is our standard of care for all of our intubated kids. Our trach kids, we're kind of 50-50. If they've got a big leak and it's not very
Okay.
effective, if you're using it for trending purposes, then that's fine. But if you're going for accuracy, you're not going to get it. But if all of our intubated kids, we do end tidal monitoring, and that's an expectation. Patient's temperature, if it's out of whack, we have the ability to do skin temp on our monitor and esophageal temps. So realize you have that option and you can monitor that way. Cabin temperature is regulated. If the cabin temperature is out of range, and there's actually card in every ambulance as to what the temperature should be. If the cabin temperature is out of range, then you have to document what you've done for the patient. Did you give them extra blankets? Did you increase the ambient temperature? Did you decrease the ambient temperature? And then in those situations, you're supposed to take their temperature every 15 minutes. So if the temperature of the unit is out of range, it's easier just to put a skin probe on them because you're going to be documenting temperature all the time. On our Zoll monitors, there's the ambient temperature and then the patient temperature. So you can get both of them off of the monitor. There's also a thermometer in each ambulance that does the ambient temperature along with the ambient temperature on the monitor. Different scoring for pain scales, whichever scale is applicable to the patient, of course. And then AVPU, Glasgow Coma, and then you have your ability to put any comments in as to why the patient is not intubated with the GCS of 7 because that's their baseline. Whatever you feel needs to be added. And this is where I put down like my first set of vitals per outside hospital overhead monitor or patient transition to transport monitor. Whatever, unable to obtain blood pressure, patient agitated. Whatever you feel needs to go with that set of vitals, that note will go with that reading only. Art line, if you're doing an art line, I will let you know. The art lines are a little trickier to get a good reading in the ambulance because it tends to shift more where your transducer is.
Okay.
You also have all the road motion. So we do a little bit more correlation if you're doing an art line with the manual or with the non-invasive as well, just because with the road motion and the shifting and things like that, you have a little bit more variability. Where in the unit, you put the transducer there, the transducer's not moving.
Yeah.
With us, it's moving. And then that's more NICU stuff. Hit OK for each thing that you put in. If you just do it and then click out of it, you're not going to save it. You can do add another as well. And stuff that you had in there should populate again. But always hit OK at the end of it.
Okay.
So assessments, you can bring it up here and go through the box system. I find it a lot easier. We've got power buttons on this side that give you a little bit of ability to do some tools. And I find that the assessment is easier on this section because it's blocked out this way.
Okay.
Than going down the grid. And you can do an all normal and then go in and say what's not normal on there.
Oh, nice. Okay.
You can do your click buttons, or you can do a free text detail section. I'm a big proponent on if you didn't physically look at it and you've been reported that there's an issue, then that's fine. You don't have to break down a dressing on a wound. You can document reported as 3-inch laceration, dressing dry and intact, not removed by team. This is where you get one of my stories. I testified one time, the worst testifying I've ever done. The defense attorney was a complete and utter asshole. But I had documented that the patient had a lac. And on the stand, he brought up a big 8-foot screen and he had tabers up there. And he's like, I'm not medical and I've searched everywhere to find out what LAC stands for and I can't find LAC anywhere. And I'm like, I apologize. It's a common medical abbreviation. We use the term LAC to stand for laceration. And he went, well, I kind of thought that's what you meant. So I looked, and laceration is the interruption of the skin cells over a bony prominence due to blunt force trauma. This person had been cut with a knife. So it was, do you always make up terms to fit what you want the chart to say? It was totally painful. But I learned if I'm going to use a term, I need to know what the meaning is. And even though laceration sounds more medical than cutting, if you're cut with a knife, it's a cutting.
Right.
So always make sure your terms are good. And if you didn't look at it, you can definitely put down what you were told it was, but always put down reported as.
Okay. I'll pause and go to the back.
Yes, please. I don't know how to pause. How do we pause? All right, if it's still recording, take a bathroom break. Right. Feel free to put down any bizarro stuff in the assessment. that is their patient's baseline and just clarify it as baseline. Half of our kids will never have a GCS of 15, but it's their baseline. As long as you qualify what's going on, you're good with that. When you do your assessment through here, there are going to be some things that you need to fix when you go into it. So just follow back down under this and just make sure everything's good. Like if you put down that the patient is a respiratory patient, when you get down to the respiratory section, there's another tab that you have to do for if there are retractions.
Oh, for like, where is this pattern?
Yeah. So if we mark where are we going? If we mark that there are retractions,
Okay.
then it will give you another box that you wouldn't have normally. So just always verify that it says everything that you want it to say. And then there is always a free text box in the section of each system.
So that would be where you would chart like per patient's baseline, per family. Or
Right.
Okay.
The next section here is procedures. The procedures are the only time I clarify who did anything. What I do, when you click the vitals, it's going to pop up and it's going to have somebody's name there. I always delete the name because as far as I'm concerned, we're a team and we're both responsible for monitoring the vitals. We're both responsible for what goes on there. But if a procedure is done, it's done by a particular person. Anyone who's listed as crew will pop up and you can pick whomever it is that did it. There are a number of procedures. You can do the scroll or you can do the side guide as well. You verify that an outside hospital's PIV is good. You document that. You verify the ET2 placement. You document that. You start a line. This is where you document it. So anything that you're physically performing for the patient is all going to be in here. You bag them. You initiate BiPAP. There's a ventilator page where you put down all your settings, but this is, hey, this is where we started it. This is the time that it began. High flow. So if you go in and the patient's on 10 liters of high flow and you bump them to 15, there's two separate notes. There's the, I found them on 10 liters procedure. Okay. And then there's the procedure of, I bumped him up to 15.
Wow.
Yeah.
Okay.
So, you always want to be able to state, this is how I found them, and this is how I left them, or this is what I did to them.
So if you find them on 10 liters, is that not recorded in assessment, or you still have to do it under procedure?
Under procedure, because your assessment is, you can put all that information, but it's really hard to flow on our charts. And that's why we hit it in all these different sections for the communication point.
Okay.
The in-hospital providers are not going to search through an entire chart.
Okay.
They're going to see procedures and they're going to go there. They're not going to read a 2-paragraph narrative.
So for, say you go to pick up a asthmatic and the outside hospital has a patient on 2 liters, but you get there and you think they're working too hard and you want to put them on high flow. Do you do a procedure note to say on 2 liters and then another procedure note to say escalated to 2 liters per kilo of high flow?
Mm-hmm.
Okay.
Yep. Okay. Yeah. Yeah. It's a lot of stuff, but it really makes a difference. I will tell you, in the situation if something actually goes to court. So in the real world, you have, if you think I beat you up, if you think I hurt you and you want to sue me, you have 7 years to sue me. But if you're 3 months old, the court knows that you don't have the ability to realize you've been wronged. You have until your 18th birthday to decide that you've been wronged. And then you have up to 7 years to sue the person after your 18th birthday that wronged you. So you are never going to remember this person should something happen.
Mm-hmm.
The only thing you're going to have is your documentation. So you want it to be as complete as possible. When I arrived, they were not receiving appropriate therapy this is what was going on when I arrived. You'll find that we get to a lot of our intubated kids that are on unsafe vent settings. You definitely want to document that's how you found them. Hello. So do all of your procedures. Size of procedure equipment, if it counts. This is where we're also documenting our intubations. Whether you use for video or direct laryngoscopy. So you'll put down your size here. Commercial tube securing devices. Some of the outside hospitals use commercial devices. So if you're verifying any T-tube and they have a commercial device, document that. Our respiratory therapists tend to like to switch out to tape. And if you've got a therapist with you, a lot of times they'll do that. If it's secure, a lot of times I'll leave it.
Yeah.
If it's concerning, then I change it. We have a thing that says safe, not pretty.
Mhm.
So as long as it's safe, and again, you're trying to move the patient to Children's, give them the resources that they need. If it needs to be done for safety, then you stop and do it. But if you can do it safely and it just needs to be made pretty, then it can be done when you get back to
What's
Children's.
a tube tamer?
It's another commercial device. Yeah. Number of procedure events. A lot of the things that we do, like verifying an IV, verifying an ET tube, things like that, it really isn't applicable how many times you did it. Was the procedure successful? It wasn't. It was just a verification. It wasn't a true procedure, so that's not applicable. And then if you're just doing a verification 9 times out of 10, your response is unchanged. I have a problem with this section because if I'm documenting in real time, I can't tell you if what I'm doing is working yet.
Right.
But the expectation is that you do something there. And so if we do a lot of back charting, so if it in the end it did improve the patient, then feel free to mark that it was improved. A lot of this is just spending time with it and getting to know what all your options are. You can log in at any point in time and just go through these fields as long as you just don't save anything. Or if you put the patient's name as delete, then Dan will know to delete it as long as you don't close it and save it. It's basically there for you. Medications. I'm not sure if you've heard this or not, but Children's National is retroactive and not proactive. We unfortunately at this facility killed a kid years ago with morphine. Not the team, the hospital itself. There was a kid in the PICU that was ordered a large dose of morphine, given by the nurse, multiple shifts. And the child did not survive. So that was many years ago when a doctor wrote an order and a nurse gave it. Now you know that a doctor writes an order, second doctor verifies, a nurse pulls a med, second nurse verifies. We don't have that ability to do that on transport. You have a partner, so you're both verifying meds. So on this section, when you put down a when you give a medication and dose verified by, you can do both of your initials and that qualifies. But that is our way of doing a double check. And the expectation is when you are giving a med with your partner, you turn to your partner and go, hey, I'm giving morphine 0.1 per kilo. Patient is 11 kilos, so I'm giving 1 milligram. This is what I got. This is 1 milligram per ml, and you show them the syringe. You can both independently write down, or you can do a verbal share and your partner can share back, but you should both agree on that dose before you actually administer it.
Okay. Is that for any medication or just narcotics?
Narcotics, highly concentrated electrolytes, anything that's considered to be a high alert medication.
Okay.
I do it for most of them just because if I do it, if that's my standard, then it's not going to seem weird for me to do it at another time. So time administered, medication given. We have a full list, a pick list that is pretty extensive. But you can, if it's not something that's in the pick list, you can do a free type. Continuous infusion, we tend not to do continuous infusions because we're giving a dose and it's titratable. We're either doing a bolus of 20 per kilo or doing an epi-drip at 0.01 per kilo so it's a dose and it's not usually a continuous infusion. Maintenance IV fluids, we'll show that in a second. That's something different.
Oh, that's not under continuous infusion?
So it's a different setup.
Okay.
So IV fluids
Oh, okay.
is if you're doing maintenance.
Okay.
But boluses and things of that nature, if you're given 5 per kilo of 3%, I consider that a medication and
Right.
not an IV fluid.
Okay.
So your dosage, it asks you a lot of information. So your dosage is in units, are you milliliters per hour? And then it'll ask you the concentration of the medication. I will tell you, my cell phone is my biggest friend when I'm on a busy call, because I'll just take a quick picture of the vial because I know what I'm doing the math with my partner on the scene. But when I go back to document, because I haven't had a chance to document while I'm running the call because I'm so busy, I'm like, oh shit, what was the concentration of that?
Okay.
And because you need to fill it in, it's easier if you just take a quick picture of the vial because we know you're doing the math there.
Right.
So that way you'll do the math again when you do your documentation, but you're not having to run and open up a drug bag and see what the concentration was at that point in time. And because of the drug shortages, it's not standard anymore. It may have always been 50 milligrams per 100 mLs, and now it's 2 grams and 250. So it's something that it's just easy to keep track of. Route and site, of course, all of these things need to be put in. Medication authorizing physician. If you're enacting a life-saving protocol, this is via protocol. Otherwise, it's the doctor that you actually chatted with. Who verified it again? Both of you. I like to put both of our initials in this section, and then response to meds if you know it, if there was a complication. And then again, okay saves everything. IV fluids. So if you are continuing IV fluids from an outside hospital, you have to take responsibility for it, so you have to document it. There were a lot of people at one point in time, it's like, oh, I'm just continuing their D5.5. They started it, I'm not starting it, I don't need to write it. No, you're responsible for it for the time that you're with it. So you have to put that you're doing it. You're picking up a PICU kid that's on 6 drips, you're not changing anything. You still have to document each individual drip and every portion of it because you're responsible for it. Trying to think. Yeah, these are just basic fields. Ventilator settings. If the patient's on a ventilator, then you would put down how you found them initially, and then in the comment section, patient found on these vent settings on arrival. And then we do a full note every time you change the vent settings.
Okay.
You change the rate, you change the FiO2, you change your PEEP, your PIP, any of that. It's a full note for the change in the vent
So
settings.
do like that and add another and
Mhm.
put so if you arrive on certain vent settings, you would put that in, then add another to put the vent settings that you change them to, then add another if you change them on row.
Right.
Okay. This is a lot of training.
There's an awful lot of charting. I mean, a busy call can take me 2 hours to chart.
I won't complain about sermon charting ever again.
But again, it's a little bit more because we have, our oversight is not right there. So you really
I
have
get
to,
it. It's just because it's all verbal.
right.
So there has to be a record of your verbal communication and what you did, because otherwise no one knows.
Now, again, everything on the phone is recorded. But the way we have our recording system set up, it's for training and education. So if you have it set up as a training and education, it's not admissible in court. So we have it for training and education, and that leadership can go and clarify everything, but it's not admissible in court. So you want to have it all. And then you want to protect your ass because somebody can say you're cowboying and practicing medicine without a license. So that's a biggie. So you really want to watch it. I want to go over one thing about the ventilator settings. When you do your med consult orders, we don't have a protocol for vent settings. So you need to get complete ventilator settings from the physician when you get your orders, mode, every aspect of it, your PEEP, your PIP, is it volume, all of that. But you also want to have a qualifier. You want to end your orders with titrate for SpO2 such and such, entitle such and such. Otherwise, you cannot make a single change legally.
Without calling back and saying something else. So
Mhm.
that gives you the leeway to make changes on route without
Right.
having to recall. And then
Exactly.
if you make those changes and you're still not successful, then you call back and say, I've done X, Y, and Z. It hasn't improved. Do you want to
Mhm.
do something else?
Right.
Okay.
Yeah. As long as you give yourself a qualifier, you can do whatever the hell you want to.
Okay.
But you've got to have that qualifier, because if you give yourself a single set of orders, that's all you can do.
Okay.
Labs. If we do an epic, then you put them in. Labs at the outside hospital, we do not take responsibility for. They're going to give you a printout of those, and the printout's going to go in the record, but we do not take responsibility for any results that the outside hospital does. This is only if we do it. And even though we upload our epics, we still put it in our chart, and it's a way of stating that we got the results and we reviewed them. This is a little awkward to fill out. So I like to stop. In this side section, it gives you the
Much
fishbone,
easier.
and it's a lot easier to fill out.
Okay.
So the other thing that you remember on the things that ask you who did what,
Mhm.
need to make sure that it's in the scope of practice of the paramedic if you're documenting that the paramedic is doing it. Otherwise, they're practicing outside of their scope. So even though you guys are together, if you run an epic, they're allowed to do a glucose, but they're not allowed to do an epic.
Is
So
it just easier than to put the labs under your name?
mhm.
Okay.
We want to keep them safe
Yeah.
and keep
like
them
I'm glad I
licensed
gotta
as
remember
well.
that. Okay.
But they'll ask you anytime you go into is this your scope of practice?
Okay. Do like Maryland rules, DC rules. Okay.
Mhm. Yeah, it's extremely variable.
Okay. Is that pace?
If you do any shocking.
Okay. Okay.
If you pace, all of that goes in here. No idea why the feedback came back.
Can our monitor pace?
So we have multifunctional pads.
Oh,
I do. Is that still there? That's still there. So we have multifunction pads. They pace, they defib, and they cardiovert.
Okay.
And everything is hands-free. Have they gone over that with you with the Zoll?
No.
Okay.
I think I've like looked at the cables and stuff, but not.
Okay. Let's see if that works again. So that's it. Blood products. So only a nurse can administer blood.
Okay.
So this will have to be you. So Children's has this wonderful policy that if the blood has already been started at the outside hospital, you can continue it. If the blood has not been started at the outside hospital, you need to call to med control. Med control needs to speak to the parent and do the risk benefits of blood transfusion. And then the parent will sign the consent after they have spoken with our med control.
Okay.
So
we have a separate blood consent.
mhm.
Okay.
So if you are starting the blood, they have to talk to med control. If it's already infusing, you don't have to talk to med control, or the family doesn't have to talk to med control.
What's the frequency of vitals during blood products?
15.
It's just,
Mhm.
is it throughout the entire transfusion?
Yeah. Well, because that's our standard.
Okay.
That's our least standard. If they're super sick, you're going 5 minutes anyway. But if they're our standard is 15. And then it's all the basic blood component stuff that you've always had. So the only other thing that's a little bit different, whether the blood is our blood that we take or whether it's blood that was started at the outside hospital from the outside hospital's blood bank, all that blood goes to blood bank when we're finished. You know how the baggies, normally when you're done with a transfusion, you take it, the baggies back to blood bank.
Yeah.
Even if they're not our blood, it goes back to blood bank here.
Okay.
We do have a policy here for taking blood with us. If you feel that you're going to need to administer blood, we call the blood bank and we alert them that we're coming to pick up blood. They get everything going. You have to go down to med control. They sign a form that's in our file cabinet in the office. They sign the blood form. You take it then to blood bank and then you sign it out with blood bank.
Okay.
They give you a cooler with the units. It's taken us many years to get this together. It's always a little halting initially, but it works out pretty good.
So this is for the patient that you're bringing in that you think is going to need blood on admission, or like you've given blood, but you think they need more.
Mm-hmm.
Okay.
Yeah. If you feel that they are going to need blood en route, that's when you take it.
Okay.
And if they don't need it, they don't need it, then we would just return it because you're it's given to you in a cooler. So it's still taken back by the blood bank if you don't administer it.
So we can, if we're going to pick up a trauma patient or something, or someone that's actively bleeding, they've got a GI bleed, and we're thinking that we're going to need a transfusion, we can get the blood here before we leave the hospital to take with us.
Mm-hmm. Yeah.
Okay.
Yeah. So, and it's also that way with any other medication. We did a down for weather, so we couldn't fly. Border of West Virginia and Maryland, someplace far away land. It was a ROSC that had rearrested like 3 times. So wasn't sure how much meds we were going to have, how much meds we were going to need. So we actually signed out a code cart from a code tray from pharmacy and took an extra code tray. You have kids with a snake bite. We get Crofab from our pharmacy. You just get a prescription from the ER doc. Kids and house fires. The what is it? I can't remember the name of the medicine for house fire kids. There's a med that you get, an IV med that you give for house fire kids, because the biggest thing with house fire is the combustibles in the home, and you need to give. I feel bad. I will find it out and tell you, but it's a medication. It turns their pee red, and basically it binds with all those toxins in the air, and you have to give that, and we have to sign that out from pharmacy.
Okay.
Oh, that's driving me crazy right now. Oh, I will remember it. But there's certain things that if you need them, we have the ability to have the ER doctor fill out a prescription, and then we pull it from pharmacy. Pharmacy is never known for being rapid. So in that situation, it always works best if one of you gets the prescription filled and one of you kind of runs into pharmacy and says, hey, this is about to come down the pike. Can you start getting it together? So, but we do have that ability, which makes it nice. All righty. Every vital is going to also give you the opportunity to do an event note. You do not have to do an event note for every vital, because that would be ridiculous. You do have to do a hello note, a goodbye note, and a reassessment note for any interventions.
Okay. So if I time the intervention with the vitals, then I just add an event note for what I did or the assessment.
So if you
associated with that vital.
If you give a narcotic, 30 minutes later, you're going to do a reassessment note.
Okay.
You give a cerebral diuretic, 30 minutes later, you're going to do an assessment note. The biggie is the hello note, how you found them, and what clued you in that there was an issue or you were comfortable, whatever, just the hello note is just how you found them. My hello note is pretty standard. Arrived to bedside, patient on mother's lap, patient on stretcher, patient in isolate, connected to overhead monitor or unmonitored, because half of the places they're not monitored. Report from outside hospital nurse, parents interviewed, consent for transport obtained, assessment initiated as documented. because my assessment's all documented. I don't need to double document. So assessment initiated as documented and continued throughout the entirety of transport. Because I didn't just look at them once, I looked at them the whole time.
Right.
And then I also put in there if there's anything that concerns me. Team discussion in regards to need to escalate respiratory support. So we're clued into it. We haven't made a decision yet, but we are aware that there's an issue. If we're at an outside hospital and we're going to do big things, if we're going to intubate, things of that nature, we always like to involve the outside facility because it's still a PR thing. We're still in their house. Some places don't want us to intubate in their hospital. They want their team to intubate.
Okay.
So they'll ask us to hold off and they'll bring their team in. That's one of those situations where, okay, we will assume care once the patient is stabilized. But you always include them. So you do a little note, team plan to secure airway, outside hospital, physician staff aware. We have had a couple of situations where our team and the outside hospital have differed on this level of support that's required. And that's fine. Just call into med control and say, hey, listen, this is what's going to happen, or this is what we feel needs to happen. The outside physician does not agree with us. Can you guys have a conversation and come to an understanding? And either one of them's going to win the discussion. You're still order-based, so you have to do what they tell you to do.
Okay.
But if you believe strongly enough in something, we're all pretty good advocators. You usually are able to convince whoever. And if you feel uncomfortable with that decision, you call Mike Quinn. But it's nice to have that backup. So hello note, anything that you've done, did it work? Did it not work? And then your goodbye note should have a couple different things to it. How did you leave the patient? A reassessment of at least the chief complaint. So if it was a respiratory complaint, is their work and breathing the same, worse, or better? Are their retractions the same, worse, or better? What is their support when you leave them? Is it a belly pain? What is their level of discomfort now? You don't have to do a full head to toe, but at least a reassessment of the complaint issue. And then transferred to stretcher with side rails up. Placed in bed with resusc team on both sides of bed. That type of a safety thing you want to clarify. I did a chart review one time for a transport team. It was a patient that had brain cancer, really sad situation. The family had moved mom close to them to a nursing home so that they could spend her last days together. Transport team brought the patient to the nursing home, put the patient in the bed, were cocky as hell in their documentation that they put the patient in the bed. The patient complained that they needed to void and the nursing home staff was advised. And then they pieced out. They thought stating that, oh, we told them that she had to pee was like their ace in the hole. So the very first documentation from the nursing home was entered room to find patient on floor, covered in blood, significant head laceration, laying in a pool of urine. Patient had a subdural and died. So the family sued with basically, we brought her here to spend her last days with her. And because of your actions, you did not provide for her safety. We lost that time. Huge check.
Yeah.
Huge
Because
check.
the other facility hadn't assumed care yet, so they were still responsible for helping her.
Bed was in a high position. No side rails were up. So they did nothing to provide for her safety, and they knew that she was in distress when she left. Had they put the bed in the low position and the side rails up, they'd have had something to go on.
But they would have had to chart that too.
Mm-hmm. Yeah. So any safety things that you do when you leave them. If you are, the meds you bring in are assumed by the team that takes the patient. Epi-drip assumed by PICU-RN. D5.5 continued on in-hospital pump. But if it's something that's a high alert pump or a high alert med, I always put epi-drip assumed by PICU nurse, dosage verified with transport nurse and PICU-RN. You're always going to go over everything with them. Our medications are not labeled the way pharmacy labels them.
I noticed that and it kind of drove me crazy in the ambulance. I was like, oh, that's really gonna bother me that like, there's
And
like I'm gonna need to like have a Sharpie or something just so I can write on the syringe. 'Cause
I would say within 6 months, everything you have is only going to be labeled in Sharpie on the
which
syringe.
I'm okay with that, but like even the absence of the Sharpie on the syringe, I'm like,
Mhm.
so we're just not even like, I know we all know that's mag, but still, really? Yeah.
Mhm.
The ICU nurse in me was like,
Yeah.
I literally was sitting there like, I'm gonna have to have a Sharpie because
Mhm.
that's gonna drive me crazy.
So I'm a Sharpie person. There has to be something on there.
Yeah.
If I take a 3% bag and I pull my dose out of it, I X on the bag that
Yes.
it's been violated. But anytime you have anything like that that you're passing off that's not labeled per hospital, make sure you have the receiving nurse's full attention
Mhm.
and you review everything you're giving to them, because otherwise they will do a SIRS report that you left them a med that was not properly labeled. So again, as long as you review that, you can document that you reviewed the medication with the receiving nurse who assumed the meds.
Okay.
But you got to do it because we do not do pharmacy labeling.
Right.
And again, you're not a transport nurse until you've been written up by the ICUs. And it will happen. But make sure you do all that. So reassessment, safety issues, anything you've transferred on. So the big thing for Jacob also is that the ability to ask and answer questions was given. So I always end my note with all questions answered, care relinquished. At this point in time, I'm not responsible for shit anymore. And I gave them the opportunity to find out anything they wanted to. So that's your big closing.
Okay.
So that's all this fun stuff. Any questions about this?
So all of the hello, goodbye notes, are those, that's all just a different event note, but
Mhm.
unrelated to vitals?
So you'll get a prompt every time you put in a vital.
Right.
It'll time it off, but you can do whatever time you want.
Okay.
You can do these whatever time you want. And then a lot of times it'll propagate with somebody's name. Again, I always X out of the name because we're both responsible for it.
Okay. So like my hello note could be associated with the first set of vitals.
Mhm.
And then at the reassessment with whatever, and then the goodbye note with the vitals at my last set of vitals.
Right.
Okay.
Yeah.
Okay.
Makes it a little bit easier that way. Then the other thing being, you do need more, if you are just doing transportation, you do need more than just a hello and a goodbye note. At least halfway through the transport, how are they doing?
Right.
Are they watching a DVD? Are they interactive? Are they sleeping? Just something that says that I actually put eyes on this patient during this $3,500 ride to the hospital. Your physician consult is the one where I do put down the name. So my physician consult is pretty much standard. And what it says is AMOTS RN, telephone medical consult with name of physician, assessment, treatment at outside hospital, and team's concerns for ABC reviewed.
Okay.
Orders obtained for. Now you'll see a lot of people will document requested ABC, received orders for BCD. To me, that is going to be problematic in court because it's so, as a nurse, why did you feel that you had to prompt the physician what to give you? Do you not have confidence in your physician? Because if they're suing the hospital for something,
Okay.
you know, well, we've already started that the very first person that met this patient didn't have confidence in this physician. Also, do you always dictate care on a patient that doesn't seem to be appropriate? Because the physician didn't agree with what you wanted to do. So what else did you do that wasn't appropriate that the physician agreed with? I will tell you, when I did medical malpractice chart reviews, I was an asshole. And I prompted those attorneys to be assholes. And who's ever doing it now is doing the same thing. And I did it for $150 an hour 10 years ago. So, you know, whoever's
So just put the orders that were received.
If you really feel strongly that you should have gotten an order for something and you didn't, then you can put down MD aware of blood pressure, MD aware of inadequate dose of ANSEF, no bridge order received. just that you were aware of it, you share that information, but it was chose not to be addressed at that point in time. Not that you asked for it and you were denied. Again, your vent orders, you want or anything that gives you a titration, you want to include that titration in there. You start your epidose at 0.01 per kilo, titrate for map of.
Okay.
Make sure you have all your qualifiers in there. Trying to think of the other thing that I just exited my brain. Again, anytime you do a PRN order, you have to include the route and the reason for giving. It's not a legal PRN order if you don't include the reason for giving it.
So you have to chart that here in the consult too.
In the med consult, yeah, the physician consult. So it says physician consult, but it's really your orders.
Okay.
So the way that we do the double checks on transport, for administration, it's both of your initials that you check the drug.
Mhm.
So for your physician consult, you can't just say give morphine.
Right.
You have to say give morphine, milligram per kilogram, total dose. You need to have all of those aspects in your order. Even if the physician only says give morphine,
Okay.
your order is going to look like you had a highly medical consult with milligram per kilogram total dose.
Okay.
Anytime you have a question, ask though, get all that information. But you need to always have milligram per kilogram total dose here. And then in your administration, you're also going to have milligram per kilogram total dose. So those are our double checks on transport.
Okay.
Trying to think. We always end everything with TORB, which is telephone order readback. So that you got your orders and then you read them back to the physician and the physician agrees with that. Now, if you go on an alpha transport, which is where we take a doc,
Mhm.
you're not doing anything fancy like this. So my alpha transports start with Dr. So-and-so, PICU MD, in attendance of transport, all orders given and carried out in real time with verbal order readback.
Okay.
So,
And that's all you have to write for your
that's it.
physician consult?
Yep.
Because they were there with you. Okay.
and everything was in real time, verbal order, and the physician was there. So I don't have to do the epi-drip, the nor-epi-drip, and all that.
Okay.
Everything was just given and received in real time, and it was all by the physician in attendance. Any questions there?
No.
Yeah, right.
Yeah.
It's a lot. It
That's
really
a
is.
lot.
So
But
I
I mean, I get it. I totally get it. It's just, I don't think I thought about the like every minute thing is not a given. You know what I mean? Like, I feel like a lot of times you think, well, if I did this, then obviously I did that. And now realizing, but you actually have to say, I did this and I did that
Mhm.
and not. So I think just thinking stepwise instead of just, I started here, I got to here.
right.
So I feel like it's all the stuff that you do anyway, but take for granted.
Mhm.
And now just having to actually write it to say that you did it. This
Exactly.
is like the definition of if you didn't report it, you didn't do it.
Exactly. But I always like to let everybody know too, I've been on the team for 15 years now. I've had 2 subpoenas in 15 years. So that's pretty decent. I also, for 12 years, did forensics, where there was a 100% expectation that everything I did would end up in court. And less than 10% of those things actually went to court. Maybe 40% of them I got a subpoena on, and only 10% of them went to court.
Yeah.
So
far, I've only been questioned once. And it sucked because I was charged. And so my name's associated with everything. Like
Mhm.
I'm doing the documentation for the admitting nurse, but it looks like I'm documenting X, Y, and Z. So then I
Right.
had to go and explain back that like at one point the nurse document, it was a kid who had a hypoglycemic seizure and the PACU didn't check her sugar. And by the time he came to our unit, he was like less than 20 and
Mhm.
horrible, like neurologically devastated.
Oh, damn.
And of course, the family's appropriately suing because then there was a delay and us admitting him to the CICU and why was there a delay and all of this stuff. Luckily, the delay was day shift, but I had to speak to we got a glucose on admission and Cerner had uploaded the glucose at, 1940, but the nurse documented at 1920 that there was a glucose of X, Y, and Z, but that didn't correlate with the time of it. So how was that possible? Did that nurse go to CT and get the glucose? And I was like, that's not likely. We don't assume care, blah, blah. But you realize like something that like the timeliness of when you say you did something has to correlate with every other evidence that it was done.
So I will tell you one other thing with times though. Times can be off and it is explainable because you have a multitude of timekeeping pieces. So now that everybody uses Apple Watches and iPhones and things like that, all of that is preset. But if you are using, if you can say that your timekeeper was your personal watch, the timestamp on the monitor, the analog clock on the wall, there
They're all
will be
different.
variances in times.
Okay. So you just have to be consistent with whatever your timekeeper is throughout your.
Right.
Okay.
So my timekeeper may be 4 minutes off of yours.
Okay.
So if you document something and I document something, there's explainability for that variability.
All right.
But if you go with one timekeeping piece, it's best to continue with that one.
Okay. My thing was anytime I had a patient, I would always, people adjust your monitor, you adjust your settings.
Mhm.
I would always enlarge the clock feature on the monitor with, I thought of if there's a resuscitation, I can't see that little time in the corner, but I can see when I enlarge it. And so to make sure that I'm looking at that time, I would always do that. So that like, even if you're the recorder in the back of the room, you can see the big time versus like this, like, I'm like, I know I can't see that. if I'm
Right,
recording from
exactly.
over there. So that would be like one of my first things was how do I make this clock bigger so
Mhm.
that I can see it? So that's what I'm looking at that associates with the vitals. So like if I do miss something, I can print it out from the monitor and the time is the same.
Right, exactly.
Okay.
Yeah.
Oh,
Okay.
thanks.
All right.
Transport.
We're getting closer. So number of patients transported.
Are you doing this again? Or is this?
This is the end. This is the, how did it actually end up?
Oh, okay.
So how did it actually end up? We took one person with us. Did we come back? So we have to go, how do we proceed to the facility? And then how do we proceed back to Children's or wherever it is that we're going? Again, if we do lights and sirens, we have to fill out that extra form on Protean that says everybody was in agreement. What was our decision maker for using lights and sirens? My personal is if I'm coming back for a surgical emergency and they are actually going to go to the operating room, then I'm okay with lights and sirens. If it's a surgical emergency and they're going to sit here for an hour to wait for the OR, I'm not using lights and sirens. If it's a medical emergency, I should be able to take care of that. And there really shouldn't be a reason to do lights and sirens because I should be able to handle it. But if there's a reason, then we're going to do it. I'm not going to throw lights and sirens out willy-nilly. But I've got to be able to justify if I'm going to do that.
I'm assuming our alpha calls generally lights and sirens. Really? Okay.
So they're already at a medical facility. They already have a physician taking care of them.
Okay.
We are not responsible for them till we get there.
So there's no benefit in lights and sirens necessarily going because they're already being treated. But if you pick up an alpha call, is it lights and sirens you think coming back, or it's up to the physician then to the side?
It's never up to the physician, it's up to the team.
Okay.
Because they don't have an understanding of all the operational logistics.
Okay.
So is anything going to happen in the first 15 minutes of arrival? Because that's all the most you will ever gain, lights and sirens.
Okay. If nothing's going to change in the first 15 minutes, if we're still going to be waiting for surgery to come and do a consult, the OR is not waiting, then okay.
I've had a couple kids that I've deposited directly in the operating room, but less than 5 in 15 years.
Okay.
So it's not that frequent an issue.
Okay. So it takes a lot for you to decide to be lights and sirens coming back.
That's me. Everybody has a different threshold.
Yeah. Okay.
I started riding ambulances when I was 16 years old, back in the days when we didn't wear seatbelts and things were a lot wilder. So I'm not as into lights and sirens as a lot of people are. I had my heyday. So, and then whether you came by ambulance or aircraft. How was the patient moved to the ambulance? So stretchers are default, but some of our rad run kids want the autonomy to walk.
Okay.
So we can let them walk inside. We'll just bring the stretcher along beside them. moving to the ambulance is one way. Like if some kids we take home,
Mhm.
we'll carry on a reeve stretcher or a stair chair or something like that. But pretty much our default of how we move the patient is always the stretcher. Position of the patient, they can be however you want them to be. Our big thing is, remember, head injuries where I was doing 30 degrees, head of the bed 30 degrees, and you need to document that so that you clarify somewhere that that's actually how you did it as well.
Is that not an option here with position?
So all of a sudden starting to wonder right now. Other,
Okay.
and then if you hit, okay, other. Most of the others give you an extra other box to work with, but okay. Patient secured by. If they get a PD mate, if they're small, they fit in a PD mate, they get a PD mate. If they are a little big for the PD mate, but they're twisted sister and they're spastic, we have the PD mate plus. Have you seen that?
Yeah.
So if they fit in a PD mate plus and they're not going to sit there perfectly, then I'm putting them in a PD mate plus. Anybody who fits in a PD mate, that means the regular seatbelt system is not going to secure them well, so they should always go in a PD mate. My big thing for the PD mate, the shoulder straps should be at the shoulder. A lot of times, a lot of our EVOs that are newer and aren't as well versed with the PD mate won't have enough butt bumps on them, so the shoulder straps are way up here. There should be no space between the shoulder strap and the top of the shoulder. A good tight roll under the PD mate itself, and then on top of the PD mate and underneath the bum usually gives enough lift for the smaller kids. The sternal notch should be actually at the sternum. So it's important that that's put on properly. But you also mark whatever securing device you use. Did you use the PD mate? Did you use the PD mate plus? Did you use the NeoMate? And then to me, everybody gets seatbelts and shoulder straps on, or seatbelts on top of it. They may not get the shoulder straps if they're using the PD mate.
Okay.
But I always put a seatbelt on top of it, which is overkill, but for me, it feels safer. So that's what I'm going to do. Baby board and PD board, have you seen those? Okay. If you use those, it's a little bit more cumbersome to secure them because that board itself gets strapped to the bed and then they get seat belted on top of it.
Okay.
But it's a great moving and securing devices for the kids if you want to be able to manipulate them. If they're your intubated trauma kids, it's just so easy because then all you're doing is picking up the board and you're not, who's got a shoulder, who's got an arm, are we manipulating the C-spine? Personnel, what OSHA stuff did you have on? We're always loop surgical mask in this wonderful time of day. But anything else that you used, if you're going out for a COVID PUI or known COVID, the N95, of course, and then did the patient wear a mask the entire time? If they have a mask or oxygen mask, a NEM mask, that doesn't count as a mask. It's got to be a regular mask. Passenger safety brief. If you bring a parent with you, you're telling them that you're wearing a seatbelt the entire time. That's a safety brief.
Yeah. Okay.
So just clarify that you did that. So again, this comes as an input imported from your CAD. Where are you going to? We are always a hospital. And then did you go to the ER? Did you go to not the ER? If you go to not the ER, you have a couple of choices. Did you go to the PICU? Did you go to the PEDS floor? If you go to the PEDS floor, it's going to prompt you to put in a PEDS score. So we have these worksheets over here. I don't have anything let up, but if I put down that I went to the PEDS floor, it's going to make me do a PEDS score sheet.
Okay.
So a lot of these things that you put in there, it triggers another form of paperwork. So we'll just do that. Safety check completed in the ER. Have you heard of those? So some of the subspecialty teams will accept a patient as a direct admission if they get a safety check in the ER, which is basically a drive-by. Sometimes, most of the times, it's just to pacify one of the specialty teams. You go into the emergency department, the medical control physician comes up and says, "Hey, how you doing?" Talks to the parent and the child for 2 minutes. and deems them safe to go to the floor, and then you go upstairs. You may call report to the to 4 East, and 4 East says, I don't feel comfortable bringing this patient to my floor. I think they need to be seen in the emergency room. And you counter with, hey, what if I do a safety check in the ER? Oh, yes, because they think it's a full physical, I think. So you go to the ER, and the ER doc does a quickie and says, yes, they feel they're comfortable for the floor.
Do you know this like before you come back? Or when do you find out that the receiving unit is requesting a safety check?
When you call. So we always call the outside hospital 10 to 20 minutes on the way out to give them a heads up that we're coming, to get report, and to make sure they have everything copied, including the radiology discs.
Mhm.
They always forget to do that. When you're coming back, you always call the receiving unit 10 to 20 minutes out,
Okay.
either to give them full report, give them a heads up, let them know immediate bedside needs, things of that nature to make transition sooner. And then they'll let you know if they are not comfortable accepting the patient.
Okay, so then you call the MCO and say, 4 East has requested a safety check, so we're gonna bring so-and-so in.
Mhm.
And then do you then call the charge nurse to figure out what room to put the patient in?
It's
since they
in the
cannot-
hallway.
Oh, it's in the hallway.
It's in the hallway.
Okay,
It's in the
Okay.
hallway, right at the desk.
okay.
Yeah.
So just the MCO to say, we're gonna swing by, can you do a safety check? Or-
Mhm.
Okay,
If the hospitalist team requests a safety check, it'll be in the pre-arrival. And then I think the ECIC puts it in a page too.
Okay.
So yes or no, if there was a safety check, we're trying to track that. At one point in time, the hospitalist wanted every kid to have a safety check. And then we went through, it's our team that's going there. So we do have a policy that if another team brings the kid in, they will always 100% do a safety check.
which that makes sense.
But we've had some issues too.
Yeah.
So that makes sense. But they're not as bad as they used
That's
to
so
be.
time consuming for the MCO
Mhm.
on top of all of their other things. who's
Exactly.
Now not out of assignment.
Right, exactly. So we've got that. And then patient admitted to whatever room that they went to. Receiving MD is, you can either put down who is actually here when you get here, but a lot of times you don't know. You can put down who you did med consult with, or you can put down who the initial accepting doctor was. It's kind of varied. It doesn't have to go crazy. It's not too specific. The most important is that who your med consult is, because that's where the chart goes to for your signatures. So this is where the level of service that you actually provided. This is the one that it matters for billing. Did you do something that was outside the scope of a paramedic? Was a critical care paramedic allowed to do what was done? Our critical care paramedics outside of Maryland can do high flow. They can do CPAP. They can do some medication. They can do dopamine drips, things of that nature without a nurse. So is it an expanded scope call or one that had to have a nurse on it? And the paramedics will help you figure this out too. And you'll get really accustomed to it with your orientation process as to what can be done and what can't be done. There's actually a chart in the team room, just the double desks on the right-hand side. That left-hand desk, there's a chart that says what the medics can do alone, what the medics have to have a nurse with.
Okay.
So what the medics can do alone, it'll tell you whether it's ALS or expanded scope as to what they can do. And then your final priority of the patient. This is in a perfect world. If you knew at the time that the call was dispatched, what you knew by the time you finished, what would it have been dispatched? Because it's not always the same. What we get from the outside hospital, again, an adult provider,
All right.
giving you a pediatric assessment. Is the kid really sick or not? If everything was known at that time of dispatch, would it have been a priority 1? Would it have been a priority 2? Would it have been a priority 3? What staffing would you have loved to have in a perfect world? And that's what this is. This is all perfect world stuff. I think that this kid would have been a 3. And I think it would have been really great to have had a therapist, but we didn't. So perfect world, that's what staffing would have been. And then we came back by ground. So chart and disc left with. You can put the name of the person. You can put PICU clerical staff, PICU fellow, emergency department, bedside RN, emergency department physician, but just who you left it with, because you're going to there have been situations that or transport didn't leave me any chart.
Yeah.
Well, yes, I did. I left it with so-and-so.
Okay.
Clarify that. So patient belongings left with, the easiest thing to do if it actually happens is maintained by mother, maintained by father. Anything you are actually taking and the parents don't come with you, then by all means clarify, patient's blankie, patient's binky, or, personal items, patient's cell phone, personal cell phone. Teenagers, I always put down personal cell phone maintained by patient.
Okay.
Because I didn't take possession of it and they were in control of it the entire time. But make sure you clarify that. It's not as bad with pediatrics as it was with adults when you had like 700 items in the wallet and their gold chains and all that kind of stuff. But if there's anything of value, by all means, make sure you notate that. Interpreter needed. So there's a big push that if there's any question and understanding, you need to have communication in the patient's native language.
Okay.
Outside hospitals will send somebody and I go, oh, no, well, you know how to speak Spanish. And if there's any concern at all that things are not being appropriate, you just say to them, hey, I actually need your Marty, or I need your telephone line because I have to have it done by a certified interpreter.
Right.
And as long as you tell them that it has to be a certified interpreter, they're usually fine with it.
Especially because they're signing consent. I'm going over the transport consent.
Yeah. If you use a Marty, if you use a language line, that interpreter will identify themselves with a number. Put their number in, because if there's any question, that's what it goes back to. And that's also for verification that you did due diligence and you got a certified interpreter. If you did not get a certified interpreter and it was the interpreter at the outside hospital or something, like, get their name and document that here.
And they normally give you a receipt if it's like someone in person. Are we allowed to use the CNH interpreter line on our phone?
They don't like that.
Oh.
So again, they bill. They charge per
Because then
patient.
we end up paying for it when you're at an outside hospital. Okay.
Yeah.
It's so confusing.
Well, and the thing is too, if sometimes I've tried to call back here before and got an unbelievable wait because they're busy, and they are busy. There's a lot of non-English speakers here, so you may not always have access to them. So again, fill that information in if you utilize that type of a staff. This is if you are coming by flight, because there's still a couple other things that have to go in for parents at that point in time. So if you bring a parent with you, fill in their name. Oh, sorry.
I forgot what it is.
Oh, just cancel. Yeah. So the name of the person that comes with you.
Oh, okay.
And their relationship. And then, of course, I told them to wear a seatbelt the whole time, and gosh darn it, they did. Controlled substance waste. So if we have our medication that we have in our pouch and we give a portion of it and we waste the rest, we have a system here for doing that. This is not that system. This is medications given to you by outside hospitals. Some of them will give you the kitchen sink if you take their kid.
Mm-hmm.
And you've got 8 narcotics when you leave. So if you are wasting any of those, you do this here and you do it with your partner.
Okay.
Also, if I'm taking a Versed drip and I'm transferring it to the PICU, I'm documenting the amount of the Versed drip that I'm transferring to the PICU RN. At that point in time, I'm definitely using her name, and I'm documenting the volume, but I'm not documenting that in my goodbye note.
You are documenting in that. Okay.
Yeah.
So here and in the note?
No, because I'm not wasting it. I'm transferring it. Mm-hmm.
Okay.
Yeah.
Okay.
So you and your partner will waste this. So you'll just fill out all of these things. And it just is a record, but this is not for our meds. This is for meds received from the outside hospital. Chart signatures, again, drop down, timed now. It may be a day or two later before the chart is done and signed. We don't like that, but It's whatever time you actually sign it. And then you can do this kind of a signature, or you don't have to fill this section out. So a lot of people will say, oh, go ahead and sign it off for me. Or when you're done with the chart, just go ahead and sign me. Your signature here, whether you do it or your partner does it, carries the same legal implications. Whether you wrote the chart or they wrote the chart, each individual listed on this chart and signed off on this chart verifies that it is a true and accurate description of what happened during the transport. I strongly suggest you read every chart before you sign it. We've all just been ready to go and it's just to sign it. But if there's anything to it, if your partner messes up, you're responsible. You get called into court, you can't say, I did the care, my partner did the chart. Well, you signed the chart, which means that you are legally obligated to every piece of ink that's on here. So just be aware, whether you write it or not, the chart, you have the same responsibility. And then here, survey code. Have you seen the survey cards that we hand out yet? So we have survey cards that we hand out to the outside. It's a perforated sheet, and there's 4 different sections. One section goes to the referring facility, one section goes to the receiving staff, and one section goes to the family. And then there's a little just thing here that has the number on it, so you know how to what number to put in there, and they all correlate together. The reason we do this, many years ago, we were on Press Ganey. You know how the hospital does the Press Ganey surveys, but there was no differentiation between us and DC Fire and Montgomery County Fire and LifeStar and any other thing in the world. So we would get called on the carpet trying to explain something that DC Fire did, and it would take, of course, there's no names associated with it and that kind of stuff. So we're trying to figure out why there's this complaint about this kid that rode on the bench seat. No, it's not. It wasn't our transport. So the way the West Wing let us get out of Press Ganey was by doing our own system.
Okay.
It's also great because we get to find out what the focus of the outside hospital is. You know, what is a value for them? There's also an alert. If somebody does a low score, it automatically emails, because I'm the champion for this, it automatically emails me and Brian if anybody gets a low score, so that we're able to do service recovery right away. And we've had a couple situations where we got a low score because of the delay in transport. So we're able to call them back and go, hey, you know, we apologize for the delay in transport. This is what happened. We had one that was a low score because they were not pleased with how long we spent on scene. So we were able to pull the chart and go, hey, you know, this is our team did ABCD. This is this took this amount of time. This took this amount of time. We felt that this was indicated that we do this before we move the patient. You know, there's always a 10% decrease in vital signs with any transport. So that has to be counteracted, things. And then, you know, we had perfect service recovery afterwards. But it helps. Our customer is the patient that we're transporting, but our biggest customer is the referral facility. Because if they choose not to use us, we've lost a lot of capture. So that's why we like that.
Are the surveys kept in the truck?
They should be in your in the binders or the clipboards, and then there's stock in the cabinet where all the consents are kept. I always like to say too, put the name of all the team members in each of those boxes, because question 1 on the survey is, did the team introduce themselves? So a lot of people go, oh, they left me their names. I'm sure they introduced me. I may have just forgotten it. They are standardized questions, so that we are benchmarked against all other transport teams that use this program. So you can't get too creative with the questions because they're standardized, but there's a comment section on all of them. And I usually every quarter or so I post all the comments that we've got, and some of them are pretty cool. Yeah, some of them are nice to hear. So so this is something that we don't worry about. The NMSIS is regulatory. Once you get past signatures, you're done. Do you need to take a break?
No, I'm okay.
Okay. Anything on that with a exclamation point is something that has to be fixed before you can finish the chart. So you can click on this and it tells you what is missing. and you can fill in anything that you know the answer for. Again, this is going to be taken care of with the CAD import. Mileage has to be given by the EBO when they arrive, and then it's put in by ECIC into the CAD import. You can't do it without it. It's billing. We have a flat fee and then we have a per mileage fee. So that's important to the facility. If you are trying to fill a chart out and you can't remember what time you did something, if you click the timeline, it will let you know what all your little timestamps are so that you can go back and correlate everything. I use it a lot for what time did we leave, that type of thing. I always also use the timestamp on my phone for what time I did the med consult.
Okay.
Anything that can help you clue in on different issues. I don't know that one. So worksheets, anything that you have to do is going to come up here. And then there are other worksheets as well. So the Pew score, if you go to a regular care floor, you have to do 2. You have to do a hello and a goodbye. If the Pew score is higher than 5, you can't go to the regular floor, or 4, or whatever the hell
So
it
a
is.
Pew's when you get to the outside hospital, or a Pew's when you get to the unit here?
So you do both. You do at the outside hospital and you get to the unit here. But when you do your outside hospital pews, if it's high, you need to let the med control know when you're calling in for your consult.
Okay.
Hey, this is a pews that I think is going to get a cat call on the floor. Let's just go ahead and do a safety check now.
Okay.
Or, hey, this is what the pews is, and med control can say, that's fine. Send them to the floor. They can do a cat call there. But at least you've addressed it. And then you'll do a Pews when you get here. Asthma score is here. And anybody that you give albuterol to, it's going to pop up that you need to do an asthma. Anytime we do any type of a scoring, we always do a hello and a goodbye scoring. So these are just worksheets that make it easier for you to implement it into your system. So you can do asthma, croup, FLAC. So if you have a Foley, chest tube, anything of that, you can do an INO. These INO is not required. DIVA is if you start a line, they were we had some questionable success rates.
Mm-hmm.
So they were trying to figure out, was the issue the provider, the patient, things of that nature. So we went with DIVA scoring everything. If you do lights and sirens, this is the form that you fill out as to whether or not everybody was in agreement, what were the risk factors, things of that nature. Again, if you have a bronchiolitis kid, you can do your bronchiolitic score. Your temperatures are out of range. It's going to prompt you to do this. What measures did you make for thermoregulation? So those are your worksheets. You also have your power tools, which again, your assessment, you vent. So you could do the regular button for event settings, or you can do these. Everybody has a preference as to what's easier for them to use. So just go back and forth. The more you do your charting, if you have downtime, just pull out charts and take a look and see what you feel the most comfortable with.
Okay.
So when you're all done with your chart, you're going to close it, and you're either going to finish it if both of you have charted and you're not going to make any changes to it. Finish is basically locking the chart. Close without finishing doesn't lock the chart. It gets it off your board and it sends it into the system. Finishing sends it actually into the hospital's record.
Okay.
So
I would close without locking when the paramedic still needs to come behind me and sign it.
correct.
Okay.
Or you need to add more data, or you've got caught out onto another call and you can't finish it, something like that. So one of the other things that I always suggest you do is go back to the incident list. So basically, if you go to incidents, view existing, and just look at charts. Look at how people document.
Okay.
The easiest way to do it is to do a print preview. And that will bring up a PDF of the record. It takes a minute sometimes, but it's not too hideous. I always loved when I did my chart reviews, I always found that my documentation was always the best right after I'd done a case, because I was like, I will never write that, or I will always write that.
Right.
And it always helped me to figure out what was really, really stupid charting and what was good charting. So this is how it comes together, and this is how you'll see it in the actual medical record of the hospital. All your times, your to from section up top, who was there, your history, or excuse me, your meds, allergies, all of those things. Your impression section, remember, you had to do the pick list, and it was basically whatever worked the best. And then your what did you go for type deal. If you used any protocols, and then your assessment goes here. Your physician consult. So this person did MCO called, total order read back, monitor and transport, continue with your med, hold your Zofran and your NSAIDs. So this is their order, and they did end it with a total order of read back. I don't know what the NV means. So their HPI, this is why they went, this is what happened. Their event notes. So it clusters the event notes in one section, and then the vitals down below. This person did not upload the vitals from the monitor because it would have been all over the place. It would have been like 3 pages long. But it gives you a little bit what was this? Huh. Okay. Your medication administration, your vitals, and then any of the worksheets that you do are going to be at the end. So this person went to the floor, so they had 2 Pew scores. And that's it. And then you just close out of this window. I can't do it with this stupid thing up top. Just close out of this window when you're done with it. But I strongly suggest going and reading as many as you can for familiarization.
Okay.
This usually takes me longer with the more people, but do you have any questions about anything?
I don't think so.
So there's a lot involved with our documentation. We don't expect you to know it at all. And you always have your second provider that should be double checking the chart with you. If you just go page by page and block by block and fill out everything that you can fill out, I can't get out of there. Oh, well. And it will alert you if there's something that you need to do. And anytime you have those exclamation points, you just go with it.
Okay.
I love to review charts. So if you have any questions, if you want me to review your charts, I will be more than happy to. I still have a lot of people that will come to me if there's a chart that somebody feels has some medical legal implications. They'll ask me to look it over for them.
Okay.
Once you've finished it though, can you go back in and make changes?
Once you finish it, no.
Okay.
So as long as you close without finishing, you're open-ended to make any changes that you
Okay.
want to.
So if I'm already thinking, I want you to double check it, I'll just close without finishing.
Mhm.
And then, okay, after I make whatever changes.
Yeah.
If I make changes, should I have the medic who was with me review them also to make sure that he or she agrees? Even though
Yeah.
we've both signed it already, but, okay.
Yeah. Or like sometimes if the medic does a chart, they'll say, hey, I've already signed it. Go ahead and sign it. If I make changes, I'll text them and go, hey, just so you know, I did A, B, C, D. Do you want me to hold off or do you want me to finish it?
Okay.
And then they'll let you know if they want to review it or not. The other thing is there are some people that will make value statements in the chart. Be very careful not making value statements. That if parents didn't know what they were talking about, or you're concerned that they are not good parents, you can put down that the parents are poor historians. You can put down that the patient's in a bad hygienic state. You can put down that you received report from the nurse at the outside hospital, A, B, and C were not complete, or things like that, but don't put a
Okay,
value
don't make
statement down.
judgments. Okay.
The big thing is too, if you're talking to a physician, don't say that you asked for something and they didn't agree with you or something like that.
Okay.
A lot of people like to make a lot of statements and charts, and that can bite you in the ass later.
Okay.
And I think that's it.